Hi, this is Andrea, and I'm here with you for HIT 210. We are on week 16, and this is about chapter 19, hospital outpatient billing. If you would like to follow along in your textbook, I am on page 445. 445. All right, so let's take a look at hospital outpatient billing. The chapter learning objectives from the book that we're going to be looking at are explain the revenue cycle of hospital outpatient claims, explain the utilization management system and its role in hospital reimbursement, and talking about the charge master. We're also going to talk about APCs, so that'll be at the end as well. Excuse me, what is utilization review? Why was it started? And why is it important for you to know? Well, utilization review was started in the 60s because of it. Let me go back. In the 1960s, there were rising healthcare costs. And so, because of that, utilization review was developed as a process to look at reducing overutilization of resources and identifying waste. Initially, they used registered nurses or RNs in the acute hospital setting to do utilization review. However, over time, there has been more learned about medical necessity, misuse, overutilization of hospital services. And so health plans have also begun utilization review programs. Sometimes they have nurses, sometimes they have other professionals. And they look at those for medical necessity, hospital length of stay, how to contain costs, alternative procedures, all those types of things. And so you see it not only on the hospital side, but you see it on the payer side. There are basically three activities within utilization review. They are different types of reviews. There's prospective review, that is reviewing medical necessity before anything is performed. There is concurrent review, that looks at medical necessity decisions being made while the patient is currently in their setting, whether that's acute or post-acute. And then there are retrospective reviews that involve looking at medical necessity from a look back, a retrospective, looking back type of audit. After everything has been done and the claim has been paid and the dust has settled, going back and seeing about medical necessity. So those are the three types of the utilization review process: prospective, concurrent, and retrospective. And those are used, again, not just on the inpatient setting, but also in outpatient settings like emergency departments. They can be used for outpatient surgery. They can be used for clinic settings. Sometimes if you've got like oncology, you have a series of visits for oncology or radiation therapy, that can involve some utilization review. You can definitely look at utilization review for long-term care or skilled nursing facilities, um, behavioral health centers, substance abuse centers, all those types of things. So the department typically conducts an admission and concurrent review and prepares a discharge plan in all cases. This is what happens in a hospital-based setting with typically inpatients or observation patients. And remember, observation patients are actually outpatients in a hospital setting. But utilization review is also performed in the emergency department and outpatient surgery areas, among others, as I just talked about. Utilization review companies, departments exist for self-insured employers, third-party administrators, and insurance companies. So you may hear about utilization review, and this is really just to help you know what it is and how it works. So again, we're in the hospital outpatient setting, and hospital outpatient is not just outpatient surgery, but it can be physician practices, it can be clinics, it can be all different types of things like that. But when you're coding in a hospital outpatient setting, you will continue to use ICD-10-CM codes for diagnoses and background information like causation. For instance, when we were in chapter 12 and we were talking about coding for fractures, we had to, you may have been prompted as to how was the fracture caused, what was the situation. And payers like to know that kind of information. And then you'll use CPT-4 and HCPCS codes for procedures, supplies, services, etc. Because remember, you're on the outpatient side of life. And then, of course, modifiers. If you need those, you'll be using those CPT modifiers as appropriate. Now moving on to the charge master, or the CDM, charge description master. Every hospital has one, every single one. So if you're in a hospital outpatient department, you'll become familiar with the hospital's charge master. It's a list of all the billable services and items to a patient or a patient's health insurance provider. The charge master captures the costs of each procedure, service, supply, prescription drug, and diagnostic test provided at the hospital, as well as any fees associated with the services, such as equipment fees, room charges, those types of things. Charge capture happens through the charge master as an integral component of the hospital's billing process. So when a patient receives services from a hospital, providers document the encounter in the medical record, and the health information management staff or professional coders then assign codes for reporting and claim submission. And sometimes, even as charges are being entered in a particular department after the patient has left, noting the supplies that were used or the service that was provided, those go through the charge master, and they have CPT codes already attached to them, or HCPCS codes. And so those go directly to the claim, and sometimes HIM or professional coders never even see those. So that's an important aspect to be aware of. But anyway, the codes and documentation are then translated via charge capture to charge master rates. The charges are then used to bill the patient and create a claim for payers. So maintaining an accurate hospital charge master is key to revenue integrity. An inadequate charge master can result in overpayment or underpayment, as well as claim rejections, undercharging for services, and compliance violations like fraud or abuse. So, for each service, the charge master includes the following components: the item number that's assigned by the facility and unique to one service line item, the CPT or HCPCS code, the item description that translates the CPT or HCPCS code into a short text description, the revenue code that's associated with this, the charge amount or fee assigned to the service line item. If there are alternative CPT or HCPCS codes because of code overlap or additional codes are needed for a specific payer, those are also included. There's a numeric designation for the department that provided the service item, what have you, and then a general ledger number for accounting purposes. So each hospital determines its own charge master prices for the thousands of services and items that it has by its providers. While patients and payers are technically on the receiving end of charge master prices, healthcare stakeholders outside the hospital are unlikely to gain access to the hospital's charge master prices. The charges on this list are generally considered proprietary information. So if you have access to a charge master, you don't ever share it with anyone outside of your organization, ever, ever, ever. And you only share it with the people inside your organization that have a job-related need to know that information. Hospitals use their charge master prices to negotiate reimbursement rates with private payers, and most patients do not see the charge master price from their hospital encounter unless they are uninsured and must actually pay the charge master rate. Consequently, hospitals tend to set charge master prices to remain competitive and negotiate higher rates from private payers, so their prices are usually significantly higher than the actual costs of care. So to summarize, the CDM or charge master, it includes all billable services and items. It captures costs and fees of those services and items. It's updated at least annually. It's usually confidential proprietary. It is used to negotiate with payers, and it translates the services and items electronically into codes and billing information that is added directly to the claim. So some quick quiz questions. What is utilization review and when is it performed? Why is it performed? What do you need to be sure to do when you code hospital outpatient procedures? There are 3 things. And what is the CDM and what does the CDM do? Electronic claim submission. Paper claim submission is prohibited except under the following conditions: small provider claims, roster billing of inoculations covered by Medicare, claims for payment under a Medicare demonstrated topic that specifies claims to be submitted on paper, Medicare secondary payer claims, claims submitted by Medicare beneficiaries, dental claims, claims for services or supplies furnished outside the U.S., disruption of electricity or communication connections, claims from providers that submit fewer than 10 claims on average during a calendar year. Otherwise, the federal government and all payers want electronic claim submission. Paper claims are very unpopular. All right, the last topic we're going to talk about today are APCs. APCs, what in the world are these? We talked about them briefly in Chapter 18 when we were talking about ambulatory surgery centers and how they're paid, how the procedures are sort of bundled up into these APCs, and then the APCs are paid. It's also true of hospital outpatient billing as well. So that's why I've got it covered here, is it's ASCs and hospital outpatient billing. So what are APCs? APCs, or ambulatory payment classifications, are the government's method of paying facilities for outpatient services for the Medicare program. But they're also used by other payers, so keep that in mind. They were implemented in 2000. They are an outpatient prospective payment system applicable only to hospitals. So they're not applicable to physician payments. But APCs are used with ASCs. So not only are they used with hospitals, but ASCs. APC payments are made to hospitals when the Medicare outpatient is discharged from the ED or clinic and is transferred to another hospital or other facility which is not affiliated with the initial hospital where the patient received outpatient services. So if a patient is admitted from a hospital, clinic, or ED and becomes an inpatient, then obviously there's no APC payment and the hospital is paid under the inpatient DRG methodology. But if the patient is just simply an outpatient, then it is paid under APCs. And outpatient also includes observation care, it includes the ED, it includes the clinics, that type of thing. So even though it's here under hospital billing, it also includes ASC, so keep that in mind. How do APCs work? Well, each APC is composed of services which are similar in clinical intensity, resource utilization, and cost. All services identified by HCPCS codes on the UB04 claim form, which are grouped under a specific APC result in an annually updated Medicare prospective payment for that particular APC. So basically they take the similar procedures, they get grouped into an APC. If you do multiple procedures, they may fall into different APCs, and that's fine. The most expensive APC is what is paid first at 100%. After that, the lesser APCs are paid at different rates. And it really depends. There's no way to say it'll always be paid at this percent. But anyway, it goes on to say here that this payment is a prospective and fixed payment to the hospital. So for a particular APC, there's a payment that's associated with that, and that's all the hospital gets. So if a hospital can estimate, oh, this patient will likely have these 3 APCs, they can figure out pretty much kind of what they can expect in terms of payment. But anyway, I'm not going to go into all the little details, but outpatients can have more than one APC. The most expensive APC is paid at 100%. The others are paid at lesser, depending on what they are, how they are, and how that all fits in. Non-Medicare payers also pay based on APCs sometimes, and their payment structure is their own. In the hospital setting, because it's prospective and fixed, the hospital is at risk for potential profit or loss with each APC payment it receives. So they know up front what they're going to get, and they know essentially how that's going to play out. And that's really what I wanted to cover on this slide. So APCs, they are applied to ambulatory surgery center procedures, chemotherapy, clinic visits, diagnostic services and diagnostic tests, ED visits, implants, outpatient services that are furnished to a nursing home facility that are not packaged into the nursing home facility's consolidated billing. They are applied to partial hospitalization services for community mental health centers, preventative services like colorectal screenings, radiology, including radiation therapy, services for patients who have exhausted Medicare Part A benefits, services to hospice patients for treatment of a non-terminal illness, and surgical pathology. All of those are paid on an APC basis. And so that's why, as an MA, if you end up in any of those areas, you would know that the APCs would be used to reimburse the services that you provide. So that's why it's covered here, and not necessarily in ASCs, but here because it covers kind of everything. And that is really all we were going to cover on hospital outpatient reimbursement, billing, coding, and whatnot. If you have any questions, shoot me an email. Other than that, hopefully this was helpful. There is no quiz on chapters 18 or 19. It's really just information I want you to have so that you know as you go out into the field, and it's something in your back pocket. All right, last set of quick quiz questions. True or false, paper claims can be submitted instead of electronic claims if the provider organization prefers to file claims that way. What does APC stand for? True or false, ASC and hospital outpatient department procedures are usually grouped into APCs for payment. All right, that is it, I believe. Yes, it is. All right, take care. Talk to you again soon. Bye.